Hello, everyone. I think just give us a minute or two. We're admitting everyone. So once everyone is in the room, we will start. Hello, everyone. Hope I saw a couple of messages about people not being able to hear or see, but hopefully that's sorted now. So I'm Subodh Dave. I'm a consultant psychiatrist in Derbyshire, consultant liaison psychiatrist, and I'm also the Dean of the Royal College of Psychiatrists. And I'm really glad to welcome you all to this webinar happening in the South Asian Heritage Month on the topic of COVID, unity in diversity. So I'm also of South Asian heritage, and I think the last year and a bit has been difficult for all of us. And each time that we felt that we're coming out of it, something else has happened that has pushed us back and challenged us further. And for people of South Asian origin, I think who form probably the largest diaspora group in the UK, it has been quite a challenging phase with the Delta variant and the impact of COVID. So today, but in all this somberness of the impact that COVID has had, there's also hope, and there are stories of how people's resilience and effort has benefited many others. So I look forward to welcoming my panel today. Firstly, we have Dr. Sadia Muzaffar. Could we have your video on, Sadia, and all the other panelists? Sadia is like me, a consultant adult psychiatrist, and she's also a psychotherapist and done a lot of work with service user-led education and borderline personality disorder particularly. And she's going to tell us about her experience of COVID in South Asian populations. Our next panelist is Ananta Dave, who is medical director in Lincolnshire Partnership Trust and is also the president of British Indian Psychiatric Association and the chair of the college's diaspora committee, and has been leading the college's voluntary effort in supporting those who've been affected by COVID. Professor Dinesh Bhugra does not need any introduction. He's been the dean of the college, he's been the president of the college, he's been the president of the World Psychiatric Association and the president of BMA. And Dinesh, I will run out of breath, even with my marathon lungs, if I keep describing what all the things you do. So I'm going to stop there. But you remain active. You are on the Tavistock's board as a non-executive director, and clearly led a lot of work in cross-cultural, trans-cultural psychiatry. And our final panelist, Mr. and correctly said Mr. He's a surgeon, Mr. Irfan Akhtar, but is president of APNE, which is Association of Physicians of Pakistani Pakistani Physicians of Northern Europe. Is that correct, Irfan? Right. But you're also an educator, and we look forward to hearing from all of you. We're going to kick off with Sadia. So over to you, Sadia. And you'll hear from all the four panelists, and then please put in your questions in the chat box, and then I'll feed them to the panelists as we go along. Thank you.
Thank you so much, Subodh. It's an honor to be presenting alongside such big names in psychiatry. And thank you for giving me the opportunity. I think I'll make a start with a quote that probably encompasses the thread of the pandemic and how all the South Asian doctors, nurses, technicians, healthcare workers have been working throughout it. It's by Albert Camus, one of the French philosophers who wrote about the plague, and I'd highly recommend that. Lots of parallels to the COVID-19 impact on communities, and how pandemics can evoke a sense of threat and fear in the strongest and the most resilient of people. He talked about, I have no idea what's awaiting me or what will happen when all this ends. For the moment, I know this, that there are sick people and they need curing. And I would like to give a tribute to all the South Asian doctors who have died. nurses, auxiliary nurses, technicians, all healthcare staff who worked throughout the pandemic and lost their lives, and also to all the people who lost their loved ones and still continued to work throughout with great dedication in the NHS. And like you said, Subodh, although there is a somber note, we will be coming to how, which is the theme of the webinar, how through adversity, different organizations, different people, communities have come together to support the South Asian communities. So first of all, I think I'd like to focus a little bit about the psychological impact that we all are very aware that COVID-19 has had on all of us as doctors, our families. I personally know of single parents who were working throughout COVID, who had no family support or friends who would normally come and visit and help them out. Equally, South Asian parents and doctors who were looking after disabled children, who had a constant fear of if they contracted COVID through their frontline work, who would look after their children. And then again, a fear in the children. And there's a report from the Royal College of Pediatricians, which states that children of minority ethnic groups suffered from more depression and anxiety as compared to their white counterpart children. So coming to figures and numbers as well, I think there was a lot of uncertainty with the rapidly changing guidelines, and it was hard to keep on top of that whilst working. However, I think in terms of the communities, many people rely on family support or parents or be able to visit parents. I think all that was stripped away, sort of all their layers of resilience and support that normally would keep them going. Religious and community centers were shut down for these communities. And I think it's been really hard, and that needs to be acknowledged. There was a death of colleagues who were working alongside you a few weeks earlier in the pandemic, and then suddenly they've gone. Up to 75% of the COVID-19 deaths amongst healthcare support workers or NHS workers were from people of the minority ethnic groups, including South Asians, which is, if you think about it, that's quite a high number. And alone between March and December 2020, there was a figure that surpassed 883 for all the NHS staff COVID-related deaths. Now, I know that the PHE report of 2020 asserts that the pandemic didn't really generate the health inequalities, but what it's done is that the pandemic's really exposed and exacerbated the long-standing socioeconomic health inequalities affecting these minority ethnic groups, including South Asian communities. I know there's a lot of work being done by the Race Disparity Unit in conjunction with the Office of the National Statistics. But I think I'd like to highlight another bit, which many people don't know about, is that there were a lot of doctors in South Asia, India, Pakistan, Sri Lanka, Bangladesh, who were given offers to come and work in the UK and then weren't able to come in because of visa regulations. Their visa expired, their job offers were in jeopardy. And I think some of them had already arrived in the country due to take the entrance exam, PLAB. A lot of international medical graduates got stuck here. They had no food, no accommodation, lodging. And then some of them I know had actually sold their land to get to the UK. So I think they're all very relevant things. And then there are lots of organizations that we'll come to later, such as the Association of Physicians of Northern Europe, Pakistani Association, APNE, and BAPIO, the British Association of Physicians of India, and DAUK. They've done a lot of work with GMC to make the criteria a bit more flexible, to give them food, lodging, basics that you wouldn't think that doctors would be facing those difficulties. So they had to go through all that amongst the pandemic and then being in a new country, not knowing anything. It was also found in some of the reports that the South Asian doctors, they're more likely to be frontline clinicians in accident and emergency departments. They're less likely to ask for PPE. And there's something about not being able to speak up often. So those were all things that impacted on their well-being. And I think there's this question which was stipulated by the Health Education England, that who cares for the people who care for the nation's health? And I think that question has never been more pertinent or relevant as it is today. Especially, I think it's not really a sprint, it's a marathon. And I think people are now going to have the impact later on that trauma. And there's a lot of talk about PTSD, post-traumatic stress disorder, in all these workers who've been working throughout. There are socioeconomic factors such as yes, they did have some pre-existing health conditions, such as they're more likely from these minority ethnic groups, such as the Asian communities, to have obesity, diabetes, coronary care, cardiac events, and living in multi-generational households where there's at least 4 generations living in the same house. How do you actually safely manage to socially distance? And that fear of contracting COVID or giving it to your parents or the grandparents when you're living in the same household is, I think the impact of that has been quite huge. Now there's Professor Greenberg's done a lot of work now about the concept of moral injury, which I think is going to become increasingly pertinent over the next few months as we come out of these safety measures and hopefully easing lockdown. It's the concept where the South Asian doctors, all doctors, NHS healthcare workers have had to deal with certain morally or ethically difficult decisions which didn't align very well with their moral integrity. And they've had to make those decisions, whether it's to take somebody off the ventilator who's 70 or take an 18-year-old off. And they've had to make those decisions rapidly without much guidance, without much resources. And the after effects of that can lead to that concept of moral injury. So I think there's going to be a huge amount of research and work that still is going to be done around what is it that was actually responsible for this level of deaths. And is there a genetic component to this? Is it just socioeconomic? But I think that there's a lot of data that's coming out that there's a disproportionate number of South Asian communities that are represented in the deaths that have happened. And just an ode to acknowledge all the hard work that they've done, being away from families, not being able to see parents. And I know Mr. Akhtar has done a lot of work around the adult dependent visa as well, which he's going to talk a bit more about later. So I think those are all very relevant points in terms of how the impact has been psychologically, socioeconomically, and in terms of stripping away your normal support systems and networks. So over to you, Subodh.
Thank you. I think we can go straight.
Oh, we've lost Subodh there for a bit.
No, you haven't.
Oh.
Still here. Thanks very much. Thanks, Subodh, and thanks, Sadia. It's been a really good introduction. What I want to do in the next 10 minutes or so is 3 things. Firstly, when we talk about coronavirus and mental health, I think there are 3 main issues that we need to be thinking about. Firstly, it's about the impact on general population, particularly today we are focusing on ethnic minorities. But we should not forget its impact on people with psychiatric disorders who are in hospitals or in the community and who are struggling, and their families are struggling. And lastly, it's about mental health of COVID patients and those who have recovered. And one of the things that we did look at right at the beginning of the pandemic was that we think that there are 5 stages in response to the pandemic. And firstly, there's fear. Because you don't know what's going to happen. Then there's anxiety and panic, which we remember, people shopping for toilet paper and, supermarket shelves being empty and so on and so forth. And then an element of anger about not being informed correctly by the government, people who are supposed to be looking after us. And then this anger leading to a sense of depression and eventual acceptance. And in previous epidemics, I think there are clear lessons that we haven't learned. And, Sadia has already mentioned Camus' plague, but there have been other epidemics where it's been shown that high levels of anxiety, self-medication, alcohol abuse, substance misuse, and, sequelae of multi-organ failures and depression, direct and indirect contact. But also one of the major things that we shy away from talking about in psychiatry is the survivor guilt, which is particularly relevant in ethnic minorities. And we've seen issues to do with lockdowns and gradual opening and shutting down again, schools opening, schools not opening, cinemas opening, cinemas not opening, and that degree of confusion. And again, I have a personal allergy to the term social distancing. Just when you need to be socially close, we asking people to be socially distant. It's personal distance, it's physical distance, which we need to be 2 meters away, but socially we need to be close. And these terms do matter because they give very wrong messages. And lockdown has been a major problem. There's been a lack of structure, distraction, limited social contact. And on COVID itself, by the beginning of May this year, there had been 400,000 studies. Now, how do you tease out the information? How do you compare data? Because a lot of these are online surveys using various research tools, over-diagnosis of anxiety, depression, and other conditions which are often confused with psychiatric diagnosis, and normal human responses being medicalized. And what I need to be sort of covering, and Sadia again alluded to the fact that particularly South Asian groups in this country and in South Asia itself have higher rates of diabetes, higher rates of hypertension, higher levels of obesity, other physical illnesses, and there are already pre-existing impact on mental health for that. And on top of that, this whole institutional structural racism, which we've seen in lots of ways, not only in this country, but in the USA as well. And what's become very clear is that the death rates due to COVID have been 1.5 times higher in Asians or Asian British compared to the white population, 3 times higher among Bangladeshis, followed by Pakistanis, followed by Indians. And Chinese population, for some reason, had the lowest rates. And risk of dying following a positive test is 2 times higher in Bangladeshi group and 1.4 times in the Pakistani group, and 1.2 times in the Indian group. And also we know that if you got certain types of diabetes, particularly if you've got HbA1c, which is more than 58 millimoles in the past year, your chances of dying are 2.7 times. And these racial disparities are not confined to the UK. There have been in the USA, for example, in Wisconsin, the rates of death in Hispanics and Black populations were 37% compared to the 8% of the population. So Kansas, Michigan, Missouri, and Illinois were particularly badly hit. And the other factor that I want to just highlight is the issue of COVID age, which has been a concept devised by Alama, which talks about vulnerability for combination of risk factors, including age, ethnicity, sex, and various health problems. And for example, a healthy white woman aged 40 has a COVID age of 40 minus 5, which is 35. So an Asian woman aged 50 with type 2 diabetes, unknown HbA1c, has a COVID age of 50 minus 5 being a woman, but plus 5 because of diabetes, plus 20 because of the unknown HbA1c. So COVID age is 70. So those kind of things we need to be looking out for, making sure that it's being taken into account, and Sadia again mentioned BMI, and I'm not going to go that, but if your BMI is over 40, it adds 10 years. So your COVID age increases by 10 years. And similarly with a whole host of other conditions, and if people want more details, I'm very happy to email them. But equally, I think the, again, Public Health England qualitative survey, which studied 4,000 people in 17 sessions, showed structural and societal, environment, and socioeconomic factors play a major role. And we've heard about overcrowding, but we've also heard about frontline, and a lot of frontline staff, and we've heard stories about it's, if you're a bus driver or a tube driver or a train driver, you're at increased risk. And similar findings have emerged from the USA. So we just need to be thinking about how do we look after our own mental health. And one of the things that we need to be thinking about, should we be setting time limits to watch the news, making small decisions, having periods of transition, having a clear structure to the day. And for the staff, we need to make sure that they have access to PPE and they're looked after. But more important than that, we have to look after our own mental health. We are allowed to feel sad, anxious, stressed, but we also need to know when to seek help and who from. So there's no doubt that there are variations in infection rates and mortality. We need to further detailed exploration for the causes, although PHE have made a start. Social determinants are incredibly important, and we need to be very clear, Sewell report notwithstanding, the challenges of structural discrimination and structural racism. So thanks very much. I think I've reached my 10-minute point. Thanks, Subodh.
Thanks, Dinesh. And over to Irfan.
Thank you very much, Subodh. I would start by saying thank you to the Royal College of Psychiatrists to give me this opportunity to speak on their platform. I must also congratulate Royal College of Psychiatrists to take up this South Asian History Month, which I think is very unique to the college, as I don't see that any other college is marrying that kind of initiative, especially not the surgical college. So I'm a surgeon, slightly out of league here, but it is my honor to be among such distinguished panelists, very educated. So thank you very much. So my topic today is essentially a problem which has been brewing over the time, but certainly became to limelight during the pandemic, and that's the adult-dependent category of visas, which basically relates to your parents and your grandparents. So as perhaps common to many ethnic minority doctors, which make about 1/3 of the total workforce in NHS, and if you look at South Asian doctors, I think that would be about 2/3 of that big cohort of about 30,000 or 35,000 doctors or so. So essentially, as we all are, when we are young and we are trying to develop our careers, build up a life here, the only thing which matters is to do clinical excellence, come to UK and perhaps attain a consultant post. And it's not long that when the penny drops that you are getting old as the time goes past, but equally your parents are getting even older. And many of them start getting into ailments which require long-term care. And you do try initially with various trips back home. And then when you realize that the condition has gone that far that they require more support than your yearly or twice yearly visits, you realize that you need to apply, and you find that it's not as easy as you would have thought. And the factor which remained in terms of the numbers was that up till about 2012, there used to be about 2,500 or so visas granted for your parents for the whole country. The policies changed in 2012 to a fact that it became such an onerous task to achieve, and the burden of proof was so high that majority people found out that it is virtually impossible to attain a visa for your parents whom you really like to take care of. And that comes with your cultural background, your religious factors into that. And I think it is quite common amongst the Southeast Asians to take care of their elderly, especially in the later ages. The numbers dropped to a great extent. And mind you that whilst the government policy was around controlling the immigration to protect the NHS, to protect the social care, the numbers weren't great to begin with. If you look at the total immigration happening over the years, the immigration through adult dependent relative visas was only 0.06%. So it's a very, very tiny fraction. So the numbers, which were 2,500 to begin with, dropped to about 200, 300, and later it has become even less. The government published their numbers up till about 2017, and then they stopped publishing the results. And we tried very hard to find out what's happening. And it was very obvious the reasons why the information was not being shared. So basically, I'll go through the results of those in a moment. But basically, the adult dependent relative is a visa status where you can apply for your elderly parents or grandparents if they're above 65, if they, because of their age, disability, or illness, require a long-term care, which is not available in your home country. Now, that is where the challenge becomes. The definitions of disability are very, very vague in that category, that your parents are not able to eat on their own, or cook on their own, or take care of their personal needs on their own, which is such a odd thing to say, that, you know, what kind of disability would be and what level would it be before you would try to bring them here. Anyway, the numbers started to decline to an extent that people became so scared of that visa category that they were not applying for it, because if you apply for that visa status, then you get rejected, then you can't even apply for them to come as a visitor visa, which they thought that is a safe way out of that thing. The latest stages of the visa status is such that now the total visas in the last 4 years were about 50 odd in last 4 years. So you can imagine that 2,500 from 2012 has gone down to this, and it all boils down to the level of proof they want to prove, and you have to prove that even with your financial and physical support, the same level of care cannot be provided in the country. For example, if they say that your parent is blind and has a broken leg of femur, you cannot bring that parent here to take care of him or her, but you should provide some kind of care there by giving them financial support, so that somebody is going to be taking care of them over there. And it becomes virtually impossible to prove that in third world countries, whilst tertiary care or secondary care is available, the social setup in the communities is not there. So you do not have the concept of a district nurse or a liaison orthopedic nurse or a liaison psychiatric nurse available who would visit your homes and take care of your elderly. The doctors were doing that with their own help and, with their own initiatives, visiting multiple times, going down there and taking care of their parents and their elderly. But then the COVID struck. And that was the moment where, lots of tragic stories came up. There were parents who were dependent upon their children living in the UK, and the children couldn't go down there simply because of their families, simply because of many of them were actually unwell themselves. And then the flights stopped, and then the embargoes came up in terms of amber countries and red countries. And that problem, which was, big to begin with, got multiplied many times over. And there are such harrowing stories which have been shared on many platforms that it really pains you. This visa was actually appealed in 2017, and we lost the appeal on that one, where the appellate court did agree that the government is within its right to control its immigration policy, but they agreed that it was never the intention of that policy that this visa status should be completely abandoned. And that is what the effects have been because of the interpretation of the soft, woolly principles which they have agreed. For example, they say that, even if you have got a distant relative in your own home country, you should contribute and you should involve that distant relative, even if you have never met them before last 40 or 50 years, and they should be able to help and take care of the elderly. So it became so difficult to prove that the help which the parents or the elderly need can be arranged or could be arranged or could be sustained over the time for whatever lifetime they have. The other bit which the government tried to prove over here was the financial implication that the taxpayer has to pay about 150,000 for any patient who's above 80 and lives in this country. And that wasn't true either. The way the figures were drawn were very flawed. Firstly, the average age for people from Southeast Asia is between 60 to 70, so that proportion doesn't come up. Then most of the children would try to keep their parents with them. And in a study done by Apne in Nottinghamshire, where we looked at 400 community beds in the social care, we found that only 9 were involved. 9 were there where South Asian ethnic origin people were admitted, but not the whole of it. So the figures don't add up. We did a survey which was associated, which was done together in association with BAPIO, and we found that almost 90% of the doctors who replied, and that was a very big denominator of that, about almost 900 doctors applied to that, and they felt that they were very stressed because of that, and they felt that it is affecting their work, as many have to take multiple leaves and try to organize things over there. The current status as it is that about 60% of those replied that they feel that they would try to leave their job simply to go back or to go to a third country where they can take care of the parents. So we are working, the Apne and BAPIO on this mission, and I would be very happy to answer any questions in this regard. Thank you, Subodh.
Thanks, Irfan. That was very helpful and a detailed exposition of the problem. I'm sure there'll be questions about it. And lastly, Ananta, welcome to you. You can start, please. Thank you.
Yeah, thank you, Subodh, and good afternoon, everyone. It's a privilege and a pleasure to be here talking about South Asian History Month. And as Irfan Akhtar said, I think one of the few colleges, or if not the only one, where we celebrate South Asian History Month. So my talk is about, hopefully bringing together the strands that have come up in the previous speakers' talks. And I just want to expand on the theme of unity in adversity. Now, I'm of South Asian heritage. I'm originally from India, and I came to this country over 25 years ago. And I hope now I'm able to live the values and the culture, both of my Indian heritage and my British adopted country. We have a saying in India, which I used to hear very frequently, and that was "Anekta mein ekta," which means in Hindi, it means unity in diversity. And I think picking up on that, today we are talking about unity in adversity. And for me, it is about how the South Asian narrative, as of many others, has been shaped over the last 18 months or so through the lens of COVID, but how we have collaborated together and together have been able to weave a slightly different narrative, hopefully going forwards, of coming out of adversity into a brighter future. So if we look at what the South Asian diaspora have gone through, or South Asian people of South Asian heritage who might have come from other countries in the world, who might have family or loved ones in other countries abroad, or who are from this country and are of South Asian heritage, it has been a case, I think, it almost feels like it's been a case of waiting for waiting for themselves and their lives to be valued equally, like everyone else's, waiting for the restrictions to end, waiting for their turns for vaccines, waiting to be validated when they talk about the racist behaviors they have experienced, waiting for the grief to end, waiting to be able to mourn with their families and friends. So in this this concept of waiting and the despair that we can feel sometimes has been captured very well in one of the poems by Rabindranath Tagore. I love poetry, and it has helped me through this pandemic, I think, as it has helped many others. And so Rabindranath Tagore, who is a Nobel Prize winning poet from Bengal, West Bengal in India, says, "The song I came to sing remains unsung to this day. I have spent my days in stringing and unstringing my instrument. The time has not come true. The words have not been rightly set. Only there is the agony of wishing in my heart." So it has felt like that for quite a lot of the time, where people were waiting, wishing, and felt that their agony or their plight wasn't understood. But out of all this, I think especially when the second wave of COVID struck India and the other countries of the world in April or May, I was struck by how the various organizations, people, professionals, statutory organizations, NHS organizations, everyone came together. Patients, professionals came together to work at speed, whether it was to raise money, whether it was to collaborate with the communities in raising awareness around vaccines and tackling vaccine hesitancy, whether it was supporting a colleague who had been racially abused and how we could support them, whether it was supporting people going through grief. So for me, what stood out was the various diaspora organizations coming together, the Royal College of Psychiatrists working very closely with the diaspora organizations, whether it was the British Indian Psychiatric Association, the British Pakistani Psychiatric Association, BAPIO, which is the British Association of Physicians of Indian Origin, UPNE, as we've heard. So the collaboration which came together between people, between professional groups, patients and professionals, between voluntary and statutory organizations and professionals and communities has been striking. And I think it has made a difference. Whether it was more than £500,000 that have been raised through the collaborative efforts of Apna NHS, which translates into our NHS in Hindi, and which brought together quite a lot of the South Asian diaspora group of organizations. So whether it was more than £500,000 raised by Apna and similarly by BAPIO, whether it is the improvement in the rate of vaccination when we worked together with the communities, or whether it was responding to the wave of COVID here in the UK and abroad. I think collaboration has given us that hope amidst the horror and the heartache. So I just wanted to touch upon very briefly about some of the projects that BIPA undertook, British Indian Psychiatric Association, whom I represent as its president. And I have to say that the support I got from the other organizations, other South Asian diaspora organizations in the college, has been exemplary. But together, we put up immediate reflective spaces and drop-in sessions for those professionals in the UK who were going through a difficult time because of family members abroad being affected by COVID. So we put in Healing Together drop-in sessions where everybody came together to support people, professionals from all disciplines. And we are also in the midst of implementing a project called Caring for the Carers, which is supported by the Royal College of Psychiatrists, whereby BIPA and the other organizations are providing a reflective space and support, a facilitation for those who are providing counseling support in India directly to people on the ground. So those counselors are being supported and facilitated by members from the UK and with support of the Royal College of Psychiatrists. So this is an example of how collaboration has made a difference across the spectrum and has really helped us weather the pain. I mean, people have talked about the impact that has happened. I mean, personally, I think the way I see the personal power of it is, I remember in the third week of April when I started getting news about various family members and friends dying in India. In a very short space, over a weekend, I think we lost several members. And like many others, I think like millions of people in this country, I woke up having nightmares and finding it difficult to sleep. And the sheer helplessness, the abject despair that you can't be there, and that, you can't do anything. But when I spoke to other people, they were all going through exactly the same thing. And we all got together and we said, individually, it feels very difficult to deal with whatever it is going on, but let's come together. Let's set up a forum. Let's start fundraising. Let's start reaching out to people. And that really helped us feel as if we were doing something meaningful. And it has been very moving. I've heard stories where patients who were going through their own struggles, whether on the wards here or in the communities, were also asking the professionals whether they were okay. And COVID, in fact, seemed to have united people in the grief, because whether it's patients, the communities, professionals, leaders, they've all gone through grief, bereavement, and loss. So that is the power of collaboration, and that anekta mein ekta, people, diverse people coming together, is really important. So I want to end on another poem. Again, it's about harnessing and holding on to hope. And this is by John Clare, who says, "Is there another world for this frail dust to warm with life and be itself again? Something about me daily speaks there must. And why should instinct nourish hopes in vain?" And it talks about our instinct towards hope and survival, and why it's important that we nourish each and every little bit of it, because it's not in vain. That keeps us going. And although the path is strewn with rocks and thick with undergrowth and it's dark, every ray of sunshine or light helps us to light the path. And it's important that we hold on to that brief glimpse of light or sunshine and keep working together and moving towards hope. So I want to end on that. Thank you.
Thank you so much, Ananta. That's really a great poem to end on. And yeah, I can see that our panelists are joining us back. I've got a couple of questions myself, and then I think there are some in the from the audience, which I will tell you, will pass on to you. But I think I wanted to start off with this concept of moral injury. I think is this something that is a useful concept? Is it something that people have felt? I mean, I felt that it certainly resonated with me, but then a part of me, I know, also felt that, yeah, am I kind of making too much of something that all of us are feeling anyway? Sadia, you mentioned it. Do you want to kick off with a bit of an explanation around that?
Yes. So I think being what I call, we're like the wounded healers. I think we're generally less compassionate towards ourselves and sometimes to our colleagues as well. So I think there's that where you were struggling to disentangle what belongs to me and which is the external bit that's happening in the whole world around me. I think there have been some very difficult decisions that people have had to make in healthcare. Talking to colleagues in critical care, I think they seem to have been worst affected. There were private hospitals that were holding on to the NHS overflow beds. They've asked for webinars and psychoeducational work around managing their staff because they're presenting with insomnia now. I think in the last 3 months they've noticed there's more insomnia, irritability, and hypervigilance as to what's next. Even though the government regulations are easing, they're sort of almost fearful and paranoid that something's going to hit them again. So you can see that that's a sign of trauma, where you don't really trust the future as much because you're constantly thinking about preparing for fight or flight almost. So I think that's something that a lot of professionals, I think at the King's College London, are doing a bit of research around in terms of how best do employers, rather than what Dinesh said I particularly liked about that whole structural and institutional racism, rather than making it more about the tick box exercise of, oh, have you done a return to work risk assessment for the BAME staff that you employ? Is it more about what is it that you actually need? Do you need 3 weeks off to go and visit your parents as soon as it's off the red list country and meet your relatives who've died and get that closure to go to their graves? Is it about, do they need psychological support? And I think I have to say professionals, especially psychiatrists, can sometimes be the last people to ask for help. So I think there's a duty of care that we all have towards our colleagues to keep an eye out for any of those signs. And if you're line managers for any of them or trainees, I think it's important to keep that open mind that they're professionals, they're working through, but there might be some signs coming up now, just when I think the whole, they've just stopped to breathe. I think that's when it will become a little bit more apparent. Things will start.
Totally. Yeah, no. I think Irfan wants to come in. Irfan?
Yeah, I think Sadia has picked up a very relevant point, and during my attempts to do this survey, when we were talking about personal narratives, that became very obvious that you feel so bad and guilty about not being able to be when your parents really need you most. There have been issues and the stories where somebody has died and you couldn't reach down there. And there is this issue of your responsibility, whether it is social, religious, or financial, that you could not achieve at that time. And that guilt has been reflected in many ways, whether it becomes your work balance and how you do your daily activities or interact with your family. And at times there are people who have taken leave, my couple of colleagues I know about, who just couldn't cope with it, and they couldn't visit, and they couldn't work either. So it is an immense concern which has unearthed with this pandemic.
And the guilt is both ways, I guess. I think certainly I can speak for myself. I think it felt terrible to kind of leave your service as well. Time in the country was really short of professionals, but at the same time, like you said, you always worry about the fact that is it going to be too late if you leave it and then don't go and see your loved ones, So there's a real issue there. Dinesh, I wanted to talk to you about continuing this theme in a way, the burden of caring for people from a distance. I mean that's the kind of yoke that migrants carry with themselves. But in the context of COVID, I think that was just amplified hugely, isn't it? What are the factors? And I mean, can we learn something from this experience? What can we do a bit better if this kind of scenario happens again?
I think first and foremost, the scenario is likely to happen again. If not to us, it'll happen to others. And increasingly, as migration increases, I mean, I've been sort of become interested in the notion of cultural capital recently. And what I'm hearing is that we all carry our cultural capital with us. There are solid things like certificates and, but then there are issues to do with language, there are attitudes, there are behaviors, there is moral responsibility. And I think that's the bit that becomes much more intriguing, because when I just want to come back to the moral injury bit, and then I'll come back to the migration one. It's partly as professionals feeling that you're not doing your best, you can't do your best, and you're being stopped from doing your best. If you can't get your PPE and you can't go out, what do you do? So part of that then gets the tension, because you feel emotionally responsible for your parents, extended family who are back home. And you keep hearing all this horrid news that, car parks had been turned into crematoria in Delhi. And what would that do to you? That, and that's partly that survivor guilt, that here I am, I've had my both jabs. And even if I get it, I'm reasonably safe. So part of that survivor guilt, part of that dealing with that cultural capital, and partly feeling responsible but helpless to deal with the family and extended family and friends you've left behind. And what Irfan was talking about is exactly that you feel I should do something, but the system is not allowing you to. So you feel increasingly frustrated and angry. And so part of the challenge really is, that's where, organizations like APNE and BAPIO and BPPA and others come in, that not to forget BIPA, that it's about support. It's about peer support. It's about, all of us are in together, some more than others, but it's the similar kind of experience that we have to learn. And it's also, the notion of guilt and shame is incredibly important in the South Asian group. So something that, we need to be aware that how we can build on that cultural capital. And part of that is culture as a doctor, as a psychiatrist, as a surgeon, as a physician. So it raises some very interesting questions about the consequences that migrants feel, but we never talk about those.
No. I think good point about guilt versus shame as well. I think clearly that is also a factor, and especially if you've got sibs, who are then left with all the task of caring for loved ones, and it feels as if you're not playing your part at all. So I think there are the multiple layers to this. Absolutely. Irfan, I wanted to come to you and ask you about the legal route, which is what you talked about. I mean, clearly there's a moral imperative to all what you said, but is there a pragmatic utilitarian imperative as well, apart from, I mean, when you're making the case for why this should happen?
Yeah, so we have been working, and as Professor Dinesh just mentioned, it was amazing. Then when I started this campaign based on my own personal experience, I found that when I reached out to Bapio, and suddenly the whole thing opened up. There were so many people who have gone through that path. I felt that the total support, helped us so much in achieving that. So what we are trying to find out is, whilst we agree that the country is within its remit and within its right to take care of the taxpayer, take care of the NHS, take care of the social services, but there are certain things which where we can achieve. For example, when we say that there should be brightest and the best coming to the country, then the brightest and the best needs to have they have the whole package which comes with them. And there could be point-based system you could do. You could put down like a health surcharge, like insurance cap, or such as in numbers to that. There are ways around it. And incidentally, we try to do a developed countries research into that, and we found that we are an outlier in that, and majority of the developed countries have got a separate pathway to the parents to cater for their needs, because it's such an essential thing. And very rightly mentioned by Professor Dinesh again, that about shame versus your own guilt, and which comes with it. Whilst you want to be diligent, you want to be doing your job, and that becomes inculcated you while you're working in NHS. But then there is this part of you which keeps saying that you're not there when you're needed, and you're not there what you are supposed to do. So what we are trying to achieve here is, between us and Bapio, is that we are asking the government to revisit those rules and make it humanly possible. It is not just right that you apply 1,000 applicants and the first time success rate is 0, and on appeal, which comes after 2 years, you get 35 in 4 years. That almost is defeatist to the cause itself. So that's what we want, that whilst we would be supporting the immigration policy, but we want some secondary legislation review here, that it becomes achievable, as even the appellate court said so.
Ananta, did you want to, sorry, I missed your hand. Did you want to come in on a previous
that's all right.
point?
I'll wait for Irfan to finish his point.
Yeah, so sorry,
Okay.
I'm done. Thank you, Ananta.
Fine. So I just wanted to pick up something in connection to what was being said about supporting staff here. Sadia, you mentioned people, who might need leave to go and visit their loved ones, for example, or just take time out. And I just want to make a point about the importance of compassionate, sensitive leadership here. Most of us work within organizations, and I have, unfortunately, through the Healing Together sessions, heard stories. This is across the NHS, not any particular specialty or trust. There have been instances whereby, for example, if a member of staff had lost their parents, or members of the family back in India or wherever it was, they rang in to say that they wouldn't be able to do the clinic that afternoon because they'd had news about their parents passing away the previous day or whatever. And there have been instances when they've been told, we are short of staff, we cannot cancel the clinic, you've got to come in and do the clinic. Now, I really feel of course, we can't know the full details of each individual circumstance. But I think there is something that we all can do if we are in positions where we manage or line manage or lead other people. First of all, we have a responsibility to become well-informed and knowledgeable about what it is that the various pressures people go through when they have families abroad, or the cultural understanding of what it means to deal with COVID or any other problem long distance. So, and how it is that we can best support the staff, because, and that person eventually went off sick for around 6 to 8 weeks. Whereas I think the support that could have been given to that person at that stage and canceling that clinic would have meant, A, that they felt valued, validated, and supported as if they belonged and that their feelings mattered. B, they would have taken much less time off and there would have been a much less impact on patient care if they had been able to take the time off and required and come back to work much earlier. So there is something about leaders being compassionate, well-informed, taking upon themselves the responsibility of learning about the cultural diversity of our colleagues and patients and what is needed. And most importantly, about the perils of short-termism. Because sometimes we take decisions which we think which will save us money or effort or reputation or whatever it is at that point in time, but we never realize the long-term implications of it. So sometimes investment at the right time, right place actually returns that investment many times over. So I just wanted to make that point really. And the last point I wanted to make was we've talked about people being traumatized and long distance, etc. But something that particularly struck me is in this country, people have been re-traumatized because there was the first wave of COVID and the second wave and 3 or 4 lockdowns. And for people who have got families abroad, who are from the diaspora, that re-traumatization has been doubled, because just as COVID in this country was improving, there was COVID in their country of origin. Just as that was improving, it's worsening here. So it seems to be such a seesawing, never-ending cycle, which actually has doubled the pain and the loss. Thank you.
Thank you, Ananta. That was really helpful. I think we're almost running out of time, but I wanted to take up your point. I think it's been great to see that you in your role as the chair of the diaspora committee, working so closely with the college. And I think as Irfan pointed out, college has been quite proactive in dealing with this issue. So I think that's something I feel very proud as a member of the college. So I think this is 30 seconds for each of you, and I think we just have enough time for that, question time style. What do you think can we do to take this further? How do we engage? Because often there's a lot of comments there about people saying that this is something, there's lack of awareness of what a migrant goes through. So how do we engage our our colleagues in that? So what are your take-home points for that? One point, please, each of you. Sadia first.
I think I would take threads from all of your expertise and all your comments, and I'd focus on compassionate leadership and just being a compassionate colleague to people around you, and to genuinely be curious, to be authentic enough to ask them how they're doing, how are their parents, and what it means for them to not be able to travel and see their elderly parents or people who've passed away. So I think a bit about that, and I think also to look at and join forces with the college, like the transcultural group, the diaspora group. They've all done a lot of work in terms of providing videos. So not just talk, but actual actions as well to help support these communities and colleagues as well. And
thank you.
Yeah, so that was.
Thanks, Sadia. Dinesh?
Organizational level, personal level, mentoring, supporting, talking formally, talking informally, holding each other's hand.
Hopefully we'll get there soon. Irfan?
Well, even if it's physically distant, but just being there is important.
Absolutely.
I would like to just thank the Royal College. I just want to say that APNE and BAPIO has joined hands, and the BMA was part of it. And there are 4 Royal Colleges which have joined us. Royal College of Psychiatrists was one of them, to raise the voice around the adult dependent relative. And we have taken it to the parliamentary group, and we have presented in all parliamentary group on immigration on this thing, and we are trying to take it forward. So keep spreading the word, please, and be compassionate to very peculiar needs of Southeast Asians when it comes to their elderlies.
Thank you. Ananta?
I would say the importance of connecting to people, listening from the heart, understanding your privilege and doing something about it, and an ability and a willingness to carry on with the difficult conversations.
Well, thank you so much. I think great note to end on. So I think I'll say that everyone take it back, I think, in your own workplace and talk about it. Talk about your own experience, share it with people. and that's the way we create awareness. So I know it's sometimes not easy to talk about it, but I think having those informal conversations, as Dinesh said, and formal conversations in proper meetings, medical advisory committee meetings, etc., just make it happen. So thank you. Good evening, everyone, and thank you again to all my panelists. You've been fantastic. So thank you once again.
Thank you.
Thank you.
Bye, everyone.
Bye.
Have a lovely evening.
Bye.